Okay, Rebecca and Jamie, you're on.
Do you want to go over the housekeeping or?
Right, so housekeeping rules video is, you can keep your video on, whatever you like. If you'd like, we'd love to see you. The audio is available, obviously. We hope that if it's not quite where you are, you mute yourself. You're not automatically muted, so mute yourself depending on where you are. And we do record these, and this will go up on the faculty development website in the next few weeks as a presentation with audio as well as the PowerPoint. And we give CME credit for the time you're here with us, but when we put it up on the website, there is no CME credit for that component, but anybody who wants to view it can. Okay.
Okay, so just to start off, there's just a couple of discussion questions. So you can, sort of think about these things as we go through the article, or if anyone wants to share anything that they would like to share right now, that can work as well. So the first one is, what has been your personal experience with implicit bias towards patients who have obesity or overweight? And how do you think implicit bias affects patient care?
Feel free to unmute yourself and chime in. We like to start with a little bit of discussion if possible.
I think one of the first things I noticed is, the terminology. So even in the discussion question, Rebecca, you're asking patients who have obesity or overweight, as opposed to, I've definitely heard kind of like presentations for patients or patients like documentation that I've seen that said this is like an obese patient or an overweight patient used as a qualifier. So I think just the language that we use can definitely affect implicit bias and the way that we go into thinking about a patient and why they're there and what we can help a patient achieve.
I think that's a really important point, because even as I was doing this presentation and I've read a lot of articles and research about obesity bias, I still catch myself writing either patients who are obese or obese patient, just like using that descriptor. And I really have to, and I've gotten much better at it, but it's really important. The language that we use is really, really important. Thank you for picking that up.
I think it's really hard because I just had this patient, and it's in the diagnosis. I mean, that's the diagnosis you have to pick if you want to bill. And then when I ran out to the waiting room to talk to her about something else, and I said to her, and if you see in your thing, it said obesity. I said I had to pick that diagnosis because that's the diagnosis. But I sort of like apologized to her and gave her a heads up that she might see that when it comes in her printout on her insurance thing. And if we want to change wording, we need to change it in the ICD 910 codes, because that's what they are.
Well, I think, Ro, I think the part of the destigmatization here is the ability to use the term obesity as a disease state and not as a personality condition. And that's like, I mean, and that goes beyond this, right? You say hypertensive patient, diabetic patient, as if like that is their primary identity. And obesity is quite literally, from a medical standpoint, a BMI over 30, right? So we don't have to necessarily have a stigma associated with it, and that would help take that away. But I think that these subtleties in language, and I feel pedantic always correcting people, but as soon as we get that to become the norm, it'll become easier to then have the conversation. Well, you do have obesity, right? We don't have to like tiptoe around that issue.
And I've definitely we have the medical students every year do the IAT, the implicit associations test. And so a couple of the years I did the, overweight, and, it's always shocking because like you always end up with biases that you don't realize you have, but I was surprised, and not surprised to see that my own bias, which the test kind of reveals for you.
I think it's also it's a wonderful starting question and also a loaded question, right? Which is what has been your personal experience with biases you didn't know you had, right? I mean, that's kind of what the question is. And so I think a lot of these end up being like catching yourself in the act, right? And then realizing, okay, I made these assumptions, and now I'm I want to go forward with a different different external approach to this now.
You know, when I took the IAT, what Lauren is talking about, we do it with the students. I took the one on weight. And of course, I came out slightly biased towards thin people. And I was so upset with myself because here I am, you know, I feel I'm a good person. And then I feel like I'm a good person in terms of nutrition. And I have this understanding of obesity from a metabolic point of view and genetic, you know, and here I am, preference towards slightly thin people. So I was so upset with myself. Like I wanted to go in and take it again and say it has to be wrong, you know?
And I think that that's really the main first step, and we'll kind of go into it, but just acknowledging that there is that implicit bias, even if it's personal, so that you can actually come up with the ways to try to address it. But I think that's the first step.
Another thing that I was going to say is we may imply that the patient is very sedentary when we see the patient is obese and that they not doing much for the health when we see just the BMI, and we go and we see there are other factors why that person is not moving as much as the person should be, and the weight is high, and that has consequences with health.
And I'm not sure if your discussion questions, or they're both on the table now, but I think as you move it towards the patient perspective, I think there's a couple of important points from just the I don't know. I was estimating the other day how many patients, maybe I've seen 7,000 patients with obesity in the last 10 years or so. And the one thing is, if you're ever interested and you have time with a patient with obesity, particularly with like, you know, morbid obesity, we're talking about BMIs over 35 or something, ask them what their experience has been with bias in and outside of medical context. And I mean, everyone's got stories. So this is pretty universal. And so I think that the other end of the spectrum too is that many of these same biases that are held by physicians, physician trainees, you know, employers and so forth are held by the patients themselves too. So there ends up being a lot of like self-recrimination during this process. So I'll shut up and let you go, sorry.
No, that's okay. Okay, so I'm gonna move on to the learning objectives. So upon completion of this session, participants should be able to appreciate the increasing amount of weight bias in healthcare and medical education and its ramification on patients' health, recognize that attitudes and beliefs about obesity can affect communication and counseling skills, and finally, identify the rationale for education of medical professionals about the uncontrollable causes of obesity as a strategy to reduce implicit and explicit bias. Just a little bit of background. So I'm sure, as everyone knows, obesity is a major healthcare issue. It leads to many adverse health outcomes like type 2 diabetes, cardiovascular disease, and according to the CDC, the prevalence of adults with obesity is 42.5% in the US, and adults with overweight, which includes obesity, is as high as 73.6%. The article that we're going to go through today is from BMC Obesity, and it's titled Associations Between Medical Students' Beliefs About Obesity and Clinical Counseling Proficiency. I think before we go into what they did in the study, it's really important to go over some of the major contributors to obesity. So genetics plays a extremely important role in obesity and obesity rates. There was a study that showed that people adopted into new families showed very little BMI correlation with their adopted parents, and rather showed a strong correlation with their biological parents and siblings. And other studies show that the heritability index of obesity is 0.4 to 0.7. And what that basically means is that it's nearly the same as height, and it's actually even higher than that for heart disease or breast cancer. Another extremely important factor, and I think it's something that was kind of brought up in the discussion, is that there are a lot of environmental factors and external factors that are huge contributors to obesity. So things like lack of access to healthy food products and the idea of food deserts, food insecurity, lack of nutrition education. And these are not insignificant factors, and it's important to understand and to appreciate just how much these factors contribute to obesity. In 2006, they did a telephone survey of American adults, and they had over 2,000 participants. And what they found was that basically they felt that obesity was caused by controllable lifestyle factors rather than biological causes or other external factors. 75% of Americans, of the participants, felt that Americans are overweight because due to not getting enough exercise, and almost 60% attributed obesity to lack of willpower or overeating. And only about 30% felt that genetics and hereditary factors had an effect on obesity rates. I think this is really an important slide, and this is really a point that the study is trying to get across and we're trying to get across, is that the perception that obesity is caused by controllable factors is a good predictor of negative bias towards people with obesity. Going into a little bit more detail about obesity bias in healthcare and actual surveys that were done. So in 2014, they did a survey of primary care physicians, and they had over 600 participants. And shockingly, 50% of them regarded patients with obesity as awkward, unattractive, ugly, and non-compliant. And they felt that treatment of obesity was significantly less effective than many other chronic conditions. In a study with medical students in 2013, which had about 350 participants, 33% self-reported a significant explicit anti-fat bias. And I think even more interesting is that over half of them had a significant implicit weight bias, and that they were unaware of their unconscious negative attitudes, which I think is something really, really important, and especially with sort of all of us in medical education. I think that this is something really important for us to recognize. And then finally, in a study of students training in health disciplines, 63% felt that patients with obesity were common targets of negative attitudes and actual derogatory humor by other healthcare providers. And only less than half of them felt that patients with obesity are compliant with treatment plans. And because of this, because of how much bias there is in healthcare, there really is a lot of ramifications of this perceived obesity bias on the actual patients. So it leads to anxiety, low self-esteem, depression. Patients who perceive obesity bias end up canceling or delaying medical appointments and avoiding preventative healthcare and screening. And because of this delay in treatment and delaying their appointments, patients who have obesity, they end up presenting with much more advanced conditions. So going into this article, they had two main study objectives. So the first one is they wanted to evaluate whether medical students' beliefs about the causes of obesity correlate with negative biases towards people with obesity. And then they wanted to see if those beliefs and biases were associated with students' ability to communicate with and counsel patients with obesity as assessed in the standardized patient encounter. The participants in the study were clerkship year students at the NYU School of Medicine. And the study was basically done in 3 parts. So the first part was a 3-day interclerkship intensive program that was called Fostering Change in Our Patients. And one of the days included topics about nutrition, obesity physiology, weight management, and disordered eating. Then the students participated in an OSCE in which they interviewed and counseled a standardized patient actor about weight management. And those standardized patient actors then rated the students' communication and counseling skills. After the OSCE and the 3-day ICI curriculum, the students completed a survey on their beliefs about obesity, as well as their attitudes towards people with obesity. And then finally, the survey responses were linked to their OSCE performance. To go into a little bit more detail about the OSCE case, the standardized patients were all middle-aged women with a self-reported BMI over 30, and the students were told that the patient had a scheduled visit to discuss diet and weight loss, and they were asked to elicit a history and then to counsel accordingly. The standardized patients assessed the communication skills using an itemized rubric, and they had 4 main domains, which included information gathering, relationship building, use of the 5 A's counseling framework, and patient activation. And then finally, the SPs gave sort of like an overall recommendation about the student. Before we go on to the results, I just wanted to know if anyone had any thoughts about the design of this study. Do you feel that the way they set up the study is an appropriate way to assess what they're trying to evaluate?
Any thoughts? Do you think that the SPs were all above BMI of 30?
That was my question too. Were they actually physically like had a BMI over 30? Because if not, that would have changed the bias of the student. You know, if they're not actually looking at somebody with a BMI over 30, they may be acting differently than what the standardized patient is trying to act.
Because I've had this issue with needing younger standardized patients for certain things, and you know, you can't put like a older person in if they're acting as a younger person, because it will help the student may not be able to get into role. I just wondered, Rebecca.
I thought the inference from the article was that they actually did have BMIs over 30.
Yeah, because they said that they had like a self-reported body mass index over 30. So I don't think they actually like weighed them, but these were all middle-aged women that self-reported a BMI over 30. So they were representative of what they were trying to represent.
I thought the design was very well done, honestly.
Yeah. Does anybody have any comments? I thought the slides that you actually presented before the study, so comment on either one. It was pretty high numbers of shock towards attitudes towards bias of healthcare students, learners, working with patients with weight issues. Is that what you normally find, Jamie, you know, just as a expert in this area?
So the answer is it depends on what level you are, you're at which you're getting to students or learners. I find that the med students that I've worked with from Hofstra, it does not seem to be a major issue. And I think it really depends on where they're doing their learning, because there's kind of an indoctrination early on that happens here where I think there's a very broad-minded approach to patients. I had a quick question about the setup. Does anyone think that it would have been better to do the survey before the interventions rather than after the interventions? Meaning, do you think that having gone through the 3-day clerkship and then had the OSCE and knowing that they're kind of being tested, that maybe their answers might have been different?
That's exactly what I was going to actually bring up. I'm surprised that they didn't ask the questions first before they went through the training and then saw the standardized patient and then did the survey. Like, I would have actually been curious to see sort of like pre and post training, kind of if the answers differ too, right? Because I think if they're getting this training on how to speak with patients, you know, about like weight management or healthy lifestyle, I would be curious to kind of see what their, you know, what their attitudes and beliefs were even before the training, because that's gonna, you know, I think we're all products of, you know, our society, and so I think it would be interesting to kind of see that too and how that correlates with their OSCE performance.
I think though with a lot of these curriculums, it's like you can do a pre-assessment and then you roll out your curriculum and then you do some kind of assessment and then you do a post survey. But the time span between those is generally so small. If you want to see if you really made a difference, you have to look longitudinally at the people from the curriculum to see over time, like if it really stuck what you taught. Because doing the pre and post in such a short amount of time, like, yeah, I learned that yesterday and I can prove that in an OSCE tomorrow and on a post survey.
Right, but I think this survey in particular is looking to correlate their implicit bias with their performance in the OSCE. right? And so their implicit bias would be best probably, I think, determined before you indoctrinate them over a 3-day intensive. And then you get a pure response from that and see whether or not it makes difference in the OSCE, where like after the fact, I would think that if anything, to be a slight bias in the answers towards like giving what they think they should answer rather than what they implicitly would do. If depending on what you're testing, it looks here like they were testing the correlation rather than a remedy for the problem.
That's true.
I think also one of the things is that if they had given this survey before the OSCE, because I was reading that when you try to, that there's a thing that when you try to suppress explicit bias, you can actually then activate implicit bias. So I wonder if that was also a factor in it. So like by giving them these survey questions prior to the OSCE, it might have affected the actual actions that they did during the OSCE, but they don't really comment on why they decided to do afterwards. But that was my thought process, that maybe that has something to do with it.
Any other thoughts? I mean, doing an OSCE obviously in a standardized way is a high quality assessment technique. So in terms of them approaching it this way, but it also would have been wonderful, and this gets into Jamie's world a little and Rebecca's and whoever else is on from that area, like authentically, what can they really do? In other words, could you do a direct observation of learners, as Karen implied, further out, you know, during some outpatient rotation where they're counseling, and can they really do this in the authentic world, that transfer from the standardized world to the authentic world?
I was thinking that because what I always hear the students when I give them feedback on some of these things, when I used to do that in my world, is, oh, it wasn't really real. It was the standardized patient. I wouldn't really do that with the patient, or it was awkward because it was, you know, fake. And that's sometimes what they use as an excuse.
So we'll see the results, but it's interesting because I think the OSCE is a very high quality assessment, you know, and simulation, but at the same time, being with the patient in the real world is always different. And especially with someone, depending how emotionally charged they are by their issue of being overweight, can greatly, in fact, impact an encounter. So I don't know how much emotion was in the OSCE. You know, that's an interesting thing. You know, was somebody anxious? Was they depressed? You know, were they ambivalent? Did they have anything about the emotions of the case, Rebecca?
No, it was very just, it was very vague. I mean, it was just basically like they were there to discuss diet, right. And but it was, didn't go into detail.
You know, talking about any of the, you know, things like substance abuse, alcohol abuse, issues of abuse of food, in any way creates emotional responses generally from patients, I would think, in my past experience of doing this.
Yeah, and I think that's part of you know, the limitations of an OSCE, which are that like obesity counseling, like a lot of other psychologically charged issues, it takes years to really get good at it. I mean, some people are naturally better than others, but you know, an OSCE can check off, did you ask these 5 questions? Did you follow up with the right things? But that doesn't, the connection that you make, the empathy that you show is really kind of harder to gauge in a standardized way. And that's something that if you're, and this is not even like, you know, they do it early at NYU. So these people could have been, you know, halfway through their second year of med school, you know, without a lot of face-to-face patient experience. So I think we would take that with a grain of salt in terms of how they, that's just for the OSCE overall. Then you look at the results, you're like, oh my God, I can't believe how much the results correlated.
Okay, so maybe we could go on to results.
Can I ask a quick question though? Can you, if you did the pre-test before the 3-day intervention, could you then, rather than do a post-test knowledge acquisition, could the OSCE serve as a level 3 identifying behavior change? So you'd know where they were before the intervention, and you use the OSCE to see if you've changed their behavior. Would you know pre and be able to do that for?
Well, you would have to do like multiple OSCEs, because the results of this show that there's still overwhelming bias anyway, right? So that and the surveys were done after anyway. So the question is, would it have been even worse? Right. I guess that's the only question, right? That would be answered by that, because clearly it didn't have an overwhelming impact. Well, I'll let Rebecca go into the results before.
Could we use a control group? Could we use a control group? That was the other thing. I mean, Rebecca said this key slide was the fact that people interpret obesity as being a controllable element. Could we have picked something else that's is smoking considered a controllable element, or alcoholism? Just as a comparison. Never mind.
Yeah. I mean, I think it would be you'd have to do independent studies to see whether. But I got to tell you, I think the eye rolling on smoking is even bigger than obesity. Yeah.
Hank, I also think it's really hard to say in an OSCE that you're actually getting to a Kirkpatrick level 3, honestly, because that's really, are they translating a behavior change into their really actual workplace? You know what I'm saying? Like, people would be hard pressed to say that was a level 3.
So you're suggesting it's just a knowledge acquisition as opposed to
knowledge acquisition, potentially attitude change if it was a Kirkpatrick level, like, 2A and 2B, but I doubt 3 really.
Okay.
Also, in this study, they weren't really assessing if that day workshop had an effect on what the OSCE and their beliefs are. They were just trying to find a correlation. So I think that the day workshop was just to give them the right tools to do well on the OSCE, but it wasn't to assess if there was an improvement, at least for this study.
Got it. Thank you.
No problem.
Okay.
So 117 students participated in the OSCE, and the demographics of this sample of students, they made a point that it's very similar to the medical school as a whole in terms of age and ethnicity, race, and gender. And at the end, 71 out of the 117 students that participated in the OSCE ended up responding to the survey. So the first thing they looked at was students' beliefs about causes of obesity. They had 9 factors or 9 causes of obesity, and 4 were within a person's control, such as physical activity, overeating, and 5 factors were outside of a person's control, like lack of access to healthy foods or genetics. And they had the students rate the causes as moderately or very important as a cause of obesity. And what they found was that the students rated 3 out of the 4 factors that were within a person's control, so unhealthy diet, physical activity, and overeating, all higher than any of the factors that were outside of a person's control. And only 26.8% felt that genetics was a very important cause of obesity. The next thing they looked at was attitudes towards people with obesity. So they had statements that were based on personal discomfort, and then statements about obesity bias, and had students rate it from strongly disagree to strongly agree. And here we see that 25% of participants either somewhat or strongly agreed with the statement, "I feel uncomfortable when examining an obese patient," which the statement itself, as we discussed earlier, is not the right way sort of to say it. And then 17% of the students said somewhat or strongly agreed with the statement, "Obese individuals don't make good decisions," and 11% with the statement, "Obese individuals are lazier than non-obese people." They then wanted to see the correlations of beliefs about obesity with causes with obesity bias. And what they did was that the survey items results were organized into 5-factor families, and basically they gave sort of this higher external attribution score which indicated the belief that external factors rather than internal factors are the most important contributors to obesity. And they found that this score was significantly negatively correlated with obesity bias. And then finally, they looked at the correlation of the OSCE performance with beliefs and attitudes. And what they found was that believing obesity was within a person's control was significantly negatively correlated with students' ability to utilize the 5 A's counseling strategy and with their overall professionalism and recommendation score. And when it comes to bias, personal discomfort and negative bias trended towards negative correlations with students' ability to counsel effectively, but it didn't reach statistical significance. So a couple of questions, I guess we could start the discussion. So what are the implications of the results of this study for either your clinical practice and or your role as clinician educator? What do you think are effective strategies for reducing bias in obesity medicine? And then finally, in clinical practice, can controllable versus uncontrollable factors that contribute to obesity be mutually exclusive?
Rebecca, do you know how much education they had on social determinants of health before this? Because it just seems to me that like the charge given to the students were to counsel the patient about diet and lifestyle, right? So whether or not it was based on, I'm not sure I'm going to be able to say this right, but whether or not it was based on bias, it's sort of like, well, these are in my domain, what you're eating, how much exercise you're doing, whatever. As a physician, I can tell you that. I can't help you if you live in a food desert. I can't help you, financially or whatever to get to work on some of those bigger systemic things, or maybe the students didn't feel empowered that those were in their realm, like, oh, they could, refer somebody to social work or something like that. So maybe they concentrated on those personalized things because that's what they felt were more something that as a physician, they had more control, themselves had more control over, sort of.
But what's interesting is the people who believed that it was about self-control did less counseling, not more counseling on those things that were supposedly in their belief system to be under self-control. So that's what I found so stunning about this is it almost like proves an irrational bias, right? Because they're taking an irrational approach to the seemingly rational bias that they have.
Yeah, they're seeing it as a character flaw in some way rather than something controllable. Yeah.
So may I ask a completely different question here that's pertinent, but how much opportunity do the students actually get to really examine an obese patient? And my naive questions, where this comes from, is simply, when I was a dance teacher and I had to show my clients dance moves, I had obese dancers. And I needed to learn to show them the moves in a different way than I would have to do with less obese clients. So it is really something that I had to just think about it. How am I going to do this in a respectful way? And where would I have to, look, and where do I have to them to focus? So my question is simply, do the students get the training? Because if they wouldn't, maybe they would just be scared, or they would just not want to be offensive in any way.
I mean, I would think if 73% of people, like you said, in the US are, adults are overweight or obese, then that's who the students should be seeing in their practices.
Yeah, I was going to say that I don't know if they have like specifically that they're, let's say, quote unquote, like seeing a patient with obesity. It's just like Dr. Bach was saying that the prevalence is so high that the likelihood that they have been is high too. These also were clerkship year students from 1.5 years to 2.5, so they might have ranged from someone that's just coming out of sort of the preclinical years to someone that already went through a certain amount of rotations. So it kind of varied there.
There actually was an article in JAMA a couple ways back by another obesity doctor from Pittsburgh, and she talked about how, we have to stop using the 70-kilogram man as the standard of what we teach physical exam on. And we do not have, unless maybe Hofstra has now, we have not evolved our curricula to teach how to examine obese patients. And the same thing, if you look at things like the New England Journal of Medicine videos about how to do procedures, they say, oh, look at the landmarks in the neck to do an IJ. And then they have a little disclaimer on the bottom that says landmarks in obese patients may be difficult to find. And that's it. And then you move on. And so I think it is important that they're not taught a comfort and a different approach and something to just make that not be the elephant in the room.
Right. Yeah, I mean, just to think about the abdominal exam, right? I mean, the abdominal exam, the way that we're taught in medical school is not, you can't do that in someone with a BMI of 50.
Can't do a pelvic exam.
You can't feel anything. Yeah.
Yeah, and to your point, Ro, we teach the students to practice on each other when they first start learning to do a physical exam in a group that's overwhelmingly of normal BMI. Not 100%, but more so than the general public.
Also then thinking about the communication aspects, does every student get the opportunity to observe a physician who's modeling like great history taking and counseling of a patient who has obesity? When we're in an outpatient setting or inpatient setting, we might have the students go out and kind of gather the history, do their physical exam, come back and report to us, and we'll go in and maybe touch on one or two key points, but have the students have the chance to like sit down and see that whole counseling aspect from beginning to end, kind of think about the language that's used, and maybe debrief afterwards specifically about the language that the precepting physician used, for example, in the room, and what they would have done differently. Do they get that chance?
I think that's very important for the remedy here, right? So they're outlining the issues with bias, particularly in early medical students. And all right, so we know that there's that bias. That bias seems to match, in certain respects, the general population's bias. So then the question is, how do we undo that so that future generations of physicians don't have that bias, right? And I think that's part of the equation. Modeling would definitely be part of it. Yeah.
I mean, you're already setting the patient up to be considered a difficult patient because you can't examine them properly. So there's already this barrier that's, I'm not going to make headway. I'm not going to reach them. They're just so.
And some of this actually comes down to how clinics are set up. So, as we are designated obesity clinics all around, even at Northwell, I find it hard to get the right size gowns, the proper tables, the proper chairs, and so forth. And it costs a lot of money. The gowns are no brainer, the right size cuffs for blood pressures. And I can't imagine how embarrassing it is for, patients sitting there with a BMI of 48. I walk in the room and there's just undergarments all over the place, and the gown doesn't close. And clearly the blood pressure was 40 points too high because the cuff was too small, right? I mean, if we set up the environment that's appropriate, knowing that this is going to be extremely common in primary care, even that you give everyone a fighting chance to kind of come in without as much of the awkwardness.
I wonder if this OSCE was framed in a way to indulge their biases, because it says here that the students were advised the patient had scheduled an office visit to discuss diet, which is a modifiable factor. So I wonder if they were just tailoring their counseling to what they were told to do in order to pass an OSCE. To a certain extent, of course.
So I think that gets to discussion question number 3 from Rebecca, and it really comes down to this is my fundamental issue with the design, is why I was surprised that the results came out as predictable as possible, and that's are these things entirely separate? So the thing is that, okay, so you say that this is genetically and environmentally more important than it is behaviorally, right? And then, but what do the genetic and the environmental things do? Well, the environment sets it up so that Americans burn a lot less calories than they used to 40, 50 years ago. Americans on average consume more than 20% more calories than they used to 40, 50 years ago. Right, and then we also know that once you develop morbid obesity, the pathways to the brain become inflamed, and the nuclei become inflamed, and the standard hormones like GLP-1 and other incretins that would tell you to stop eating stop working. Right, so in the end, we end up eating more, moving less, yada yada yada. All the things that the implicit bias is supposed to show happen, and our way out of this is we might use medications, but they all help us get to that same point. So I think I was surprised that the results came out as good as they were, given that these things were kind of staged as antithetical, but they're actually quite intertwined. And that the big issue seemed to be that there's an implicit bias of, like, I think as Lauren was mentioning, that it's more of like an anti-character bias rather than what's the single most important factor, because whether one is 1 and 1 is 2 probably doesn't matter in the end.
Right. I think there's, you think about visually a patient who's overweight or obese coming into your office that you've never met before. And I'm sure there's some visceral reaction about, am I capable of taking care of this patient? First of all, like, do I have the skills to do this? Right? Because not everybody feels skilled to do it. I certainly, as a dietitian, I felt much more skilled with other types of patients that I took care of in a private practice. So I think there is a special skill set. So thank you, Jamie, for being here with your clinic to say that we need special skills for this. Rebecca in a training program. So I don't think it's everybody who can do this type of work. And part of it, therefore, you don't have the self-efficacy to do it. It's not just bias. You don't even have the self-efficacy. Elizabeth, I know your hand's been up. Is that from before or now?
Yeah, sorry, you can lower it. Yeah.
Okay.
So Alice, to your point, we didn't have a huge response, but as a section, we surveyed a few years ago primary care physicians at Northwell across the spectrum of anywhere from the more peripheral practices all the way to the academic practice, and almost no one said they were extremely comfortable, like the highest level of very comfortable managing obesity. Almost no one said they were very comfortable managing medications for obesity. Less than 50% of people actually prescribed medications to help with obesity, and more than 50% of medications prescribed were actually metformin, which we know probably doesn't do all that much as an obesity medication. Referrals went out to different people, but it just seems to me that the comfort level is a huge factor, and there's a variety of reasons, right? From lack of time to lack of understanding to the implicit bias. I think they all factor in. Right. But you're totally right on that. Is that you're already starting with if the norm is, I think this is going to be more difficult than average patient, and I'm totally stressed for time and
right,
and I don't even know where to begin anyway. What do I do? Yeah.
Right. I think we just have to move on a little because I'm looking at my time, and this was a great discussion. Next slide. Is Wendy coming up, or your main? Could you proceed to Wendy's slide before we do main takeaways and come back to that?
Sure.
Wendy, why don't you go, and then we'll do main takeaways and see what else that people want to say.
Okay, fantastic, thank you. So we took a look at the bibliometrics via Scopus for this particular article, and what you see on the screen here are data points in which how the article is accessed, how many times by which platforms. As you can see, there's in the first box here under citations, there's 2 articles that have cited this article back. In the next slide, I'll show you what the 2 citations are in case you are interested in reviewing those. In the middle is the usage, so that indicates how many people have looked at the abstract or how many people have looked at the full text. And what I actually like to highlight are the alternative metrics as well. So under the third purple box under captures, there's a Mendeley readers, and it says 33, which indicates that 33 readers have saved this particular article into their library for later consumption, or I've spoken about this in the past sessions, but Mendeley readers saving items into their library is more predictive of citebacks rather than, let's say, someone talking about the article via Twitter. And if you look at the middle bottom column under social media, there have been 2 tweets by 2 separate Twitter users, and both of those combined followers for the Twitter users are over 10,000 followers, which indicates that there's been much more exposure, just given only 2 tweets, but then it reaches upward bound of about 10,144, I think it was, followers.
Wendy, I think I'm surprised it's not more tweets because, so I'm just wondering, like, from a social perspective, like, people don't even want to talk about the topic. It's such a complex topic. It's so difficult. Like, I don't know, that it didn't make bigger social media. I'm just thinking of all the things that make social media. Like, it's not jazzy to talk about overweight. It really isn't. There's no jazz to it. There's no, fireworks to it.
Oh, but bias now should be totally up. That's a very current
right. But in terms of bias, it should be totally up because there's so much on bias happening. You're right. But in general, there's not a lot of fireworks about overweight.
But honestly, if you look at social media, that just seem to do a lot. Obesity is not a trend topic right now. It is not. It was a couple of years back when comedians picked it up and people were fat shaming was the big deal, right? Where people really spoke up against. And that came down a little bit and other things went up, right? If you look into society, what happened. So it's really, unfortunately, it's kind of based on trends a little bit.
So, I agree. And also perhaps maybe there's other terms that describe obesity without actually using the term obesity. That might be the case in terms of social media, because we're looking at kind of natural language as opposed to something that's a little bit more controlled. If you can go to the next slide, please. Thank you. Oh, so these are the 2 citations that cite the main article that was discussed today. And so if you're interested, that's the citation information. Another piece of information I've included actually this time is data accessibility. So this particular article happens to be cataloged in NYU's data catalog. And so if you're interested in looking at the raw data for the project itself, you can access this link and it gives you instructions on how to access that original data if you wanted to take a look at that for further consumption or just kind of going more into a deep dive.
I think article number 2 here is interesting to look at.
Yes.
Article number 2.
Yeah, I agree. And actually, I was a bit surprised that it was cited for article number 1. Number 2 makes sense, but number 1 I was surprised. So I ended up looking to see where it was cited, and it was part of the discussion that they were having at the end of the article, but it just kind of caught me off guard a little bit. It seemed
I agree with you. I was a little surprised myself. Thank you, Wendy. So go back to your concluding points just out of time. Rebecca, you want to take us away with takeaways?
Sure. So medical students rate controllable factors as more important than genetics or biological factors. Attributing obesity to external causes affects ability to counsel patients effectively. And then finally, the article discusses how educating healthcare professionals about the biological causes of obesity is a strategy to combat both implicit and explicit bias. I think an important thing to note here, and something that we had discussed, was that it's important for students or any healthcare professional to understand the uncontrollable factors of obesity. But then what we were saying is that so it's important to understand that, but when you are then counseling a patient, it's important to also then think about the controllable factors, because that's something that you can actually sort of intervene on, and that'll be sort of the thing that'll get them to be able to become healthier and to lose weight. So although it's extremely important to help combat the bias by educating healthcare professionals about the biological causes, the external factors and the controllable factors are still important, and it's important to educate about those as well, because that's sort of the thing that's really going to allow for counseling and intervention.
I think it's a really good point. I know and it's not the approach that I necessarily use. Like with hyperlipidemia, I'll say to people, listen, like hyperlipidemia is probably like some component your genes and some component you know, lifestyle decisions. You can't control your genes, right? So all we can do is work on, you know, lifestyle. But I tend not to use that approach with obesity, and it's probably worth considering, you know?
I had a question, and you may have said this, Rebecca, but did you compare the non-responders to the responders in that study? Because I was surprised that there were only 71 out of 117. So it would be interesting to know whether the demographics of the two groups including percentage that were overweight or obese, whether they were the same, the non-responders to the responders.
Or even like how the non-responders did on the OSCE, like how they.
Exactly.
Yeah, they didn't go into that.
Yeah, because I think, you know, most of it, when you're doing studies like that, there are a lot, when they're non-responders, you want to show that your non-responders, the population, are the same as the responders, and that there isn't a bias to those who respond versus those who don't.
Right. It looks like that when they gave the sample demographics, they included the 117 and not specifically the 71, but that they were similar. And then they didn't ask the students they didn't ask about their own personal weight or weight category. So they didn't explore that.
That might have been interesting.
Yeah.
Yeah, that would have been interesting to explore the weight category, the BMI of the students. Oh God, that really would have been invasive.
Yeah.
that would be interesting.
Right, but it's similar to doing studies where they say, you know, count women patients versus male physicians, and, you know, so the concordance between the physician and the patient, how much that makes a difference. So.
Right. If you go to a physician who's overweight, do you feel more comfortable? Could you just go to the last slide? Last slide, just out of time. Just to let you know, you will be getting the copy of the PowerPoint, and a link to SurveyMonkey will be in there for you to complete any feedback you can give us. We appreciate feedback. We don't get a lot, but we try. And I'm really excited about the April Journal Club because I'm doing a panel for the first time ever. And I'm addressing bias and discrimination, and discrimination in learning environments to support April as Diversity and Inclusion Month. And I have 3 presenters on the panel and 3 very qualified people on the panel, as well as 2 discussants that will be there as well. So the 2 discussants will work with the Center for Equity of Care. So it should be a great session, and I hope people can join. And I want to thank Rebecca and Jamie for being here and bringing this topic forward for us, and everybody else for joining as well. Is there any last comments from anybody in the audience at all? Jenny's asking, is the survey the one we fill out for CME or no, it's the same survey. That's the survey. It's a combined survey. Anybody has any questions or comments? Going once, twice, 3
I'm
times?
really interested in having a dive into how to address these gaps in knowledge in the biological, you know, determinants of obesity. And I know that the SIUH, like Women in Physicians group, is doing a bunch of talks. I think it's a couple months from now, but it would be really great to have like someone give a talk on this. I know a lot of people would be really interested, so that would be great.
So I think you should contact Dr. Kane as our expert. Jenny is a pediatrician at Staten Island University Hospital.
Okay, great. Yeah, sure.
Okay.
It's okay. I'm an ER doc. I'm not a pediatrician.
Oh, sorry, she's an ER doc.
Okay.
It looks like a pediatrician.
Great. My husband's
Sorry, that's my bias.
Oh, I was going to say, we also have specialists in pediatric obesity too, if you need us.
Yeah.
Where is that? Who spoke?
So this is Stephanie. I work with Dr. Katzow and Adolescent
Right.
Medicine, the Power Kids Weight Management Program.
Right, great. Hi, Stephanie. Thank you
Hi.
for being on. Okay, so thank you, everybody. It is 1 o'clock and the hour is up, and I really appreciate it. And I'll hopefully see some of you next month.